Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out that Top 200 Study Guide, great refresher, at reallifepharmacology.com. Simply an email will get you access to that. Absolutely free. Take advantage of that, whether you're a student in pharmacology classes or you're a practicing clinician, just need a little refresher. Definitely a no-brainer to go snag that with an email. All right, let's get into the podcast episode today, and I am covering fibrate derivatives. It's a medication class that doesn't always get the spotlight for cholesterol-lowering medications, but it definitely, this class definitely is used periodically. So, talk a little bit about how they work, when to use them, some of the risks, and some important test prep and practice pearls. That's definitely going to help you on pharmacology exams. All right, so first off, fibrates or fibrate derivatives, fenofibrate, gemfibrozil. Those are the two most common medications. These are lipid-lowering medications, and they primarily target triglycerides rather than LDL. So if you've got somebody that we're looking to use for ASCVD and we're targeting LDL, statins are our go-to medication there. Okay, fibrate derivatives don't really come into the equation too much. The most commonly used agents I alluded to, gemfibrozil, fenofibrate, fenofibric acid. So again, those statins dominate lipid therapy as far as LDL goes, but those fibrates do remain a relevant medication to target high triglycerides. And the issue with high triglycerides is they can lead to the increased risks for pancreatitis. Definitely a good potential test question there. All right, so how do these medications work? They activate a nuclear receptor called PPAR-alpha. And when this receptor is activated, it increases lipoprotein lipase activity. This enhances the breakdown and clearance of triglyceride-rich particles, which makes sense that this ultimately causes the most significant reductions in cholesterol by targeting those triglycerides. Also can have modest effect on HDL, increasing it potentially, and pretty variable effects on LDL. So again, fibrates, we are targeting triglycerides when we're using these medications. So again, understanding elevated triglyceride levels, what's kind of that target level that we look at? So generally, again, depends upon the patient a little bit and the risk factors and things, but usually if you see a level of triglycerides of 500 or higher, the major concern here is pancreatitis and not necessarily cardiovascular risk like it is with LDL. Okay, so that's really the target, that 500 piece of it. Now, in using these medications, what kind of lipid-lowering effects or triglyceride-lowering effects would we expect? So fibrates typically reduce triglycerides in the neighborhood of 30 to 50%. Again, probably a dose-dependent, medication-dependent type effect, but that's a good ballpark target there for these medications. Again, LDL can potentially decrease slightly, maybe remain unchanged overall. It's not going to be affected too much by these fibrates in general. Lipid panels, we are going to monitor that. Obviously, we checked them in the first place to understand that the triglycerides are high and they're at pancreatitis risk. So we're going to check that, and we're going to do that for a couple reasons. Obviously, we want to make sure those triglycerides are coming down, but we can also kind of help assess adherence to the medication as well. So if they don't come down at all or they're higher than ever, we can probably go back and look, and I would say 90-95% of the time, the issue is going to be patient adherence to that medication. So those lipid panels can do more than one thing there for us. Neighborhood check is going to be usually 8 to 12 weeks. Some may do it as soon as 4 weeks if it's, crazy high and they want to make sure it's coming down. But I would say, generally it's, 8 to 12 weeks, every 3 months, those type of things, for cholesterol levels that aren't like crazy high or crazy alarming. All right, getting into a couple of differences between fibrates. So gemfibrozil, historically, that was the medication I used to see used most often when I started as a pharmacist many years ago. This medication is usually dosed twice daily, and it has a higher risk of drug interactions, especially with statins. So fenofibrate is generally preferred now, and the reason being we don't have that interaction with statins as much. There's still some potential there. But it's also only dosed once daily. So that really allows us to help, increase that patient adherence there and things. Okay. So fenofibric acid is an active metabolite of fenofibrate, and it may be used in certain patients for dosing flexibility or tolerability reasons. So those are really the most important points when comparing gemfibrozil and fenofibrate. Gemfibrozil, again, twice daily dosing, can be problematic nuisance for some patients, and then the higher risk of drug interactions, particularly with statins if a patient needs that too, versus fenofibrate. Adverse effect profile of these medications. In general, I would say the most common thing I see in practice is gastrointestinal upset, dyspepsia, those types of things. Rarely, you may see liver enzymes go up, so you may see those checked periodically as well, or if there's signs and symptoms that there's issues there for sure. Fibrates can also increase cholesterol excretion into the bile. And this can raise the risk of gallstones. Not something I see incredibly often, but something to be aware of there. Fenofibrate rarely may cause a reversible increase in serum creatinine. Generally not considered a true kidney injury, but you may see periodic monitoring for that as well. One of the most important safety topics is myopathy and rhabdomyolysis risks. Fibrates alone do carry a small risk of this muscle toxicity, but again, this risk goes up when we use them with statins. And again, gemfibrozil is particularly problematic. It has the highest risk of myopathy and rhabdomyolysis in combination with statins. It can block statin metabolism, leading to higher statin concentrations. And some statins are worse than others. I'm not going to delve into the weeds into which ones are worse there. But if we absolutely have to use gemfibrozil for some reason, that may alter the statin that you'd select and those type of things. But again, you're going to likely prefer utilizing fenofibrate over gemfibrozil because, again, it's generally a little bit safer with statins, but there is still some risk there. All right, so statins are the most probably well-known drug interaction, especially with gemfibrozil. You may also see some effects on warfarin, so if you've got a new start of gemfibrozil or potentially fenofibrate, might want to pay a little bit closer attention to that INR and bleeding risk. Also, potentially sulfonylureas. There may be a little bit of effect on blood sugar there, and increasing the risk for hypoglycemia in the near term there. So, again, paying attention a little bit to anticoagulation and warfarin if these meds are started, and then may want to do a little closer blood sugar monitoring there as well. All right, let's take a quick break from our sponsor, and then we will wrap this podcast up. If you're in the market for any pharmacist board certification study material, BCPS, ambulatory care, NAPLEX, BCM, TMS, go check out meded101.com/store. We've got tons of resources there We've helped thousands of pharmacists pass their exam, and we can absolutely help you too. So again, go check that out, meded101.com/store. If you're a nurse, pharmacy technician, med student, we've got tons of resources at meded101.com/store, whether that be books, review courses, all sorts of good stuff. If you enjoy this podcast, find it helpful, those resources will absolutely be helpful for you as well. So do me a huge favor. Go support meded101.com/store. Get some great resources, learn some cool stuff, and help the podcast as well. All right, so wrapping up, let's talk a little bit of counseling and clinical pearls, just summing some of these things up. So patients obviously should be counseled on adherence. I would pay attention to any type of muscle pain or weakness, looking out for that myopathy and rhabdomyolysis. If patients have signs and symptoms of rhabdomyolysis, muscle soreness, fatigue, dark urine as well, indicative of renal impairment and those type of things, go pay attention, go check labs, CPK, those type of things are going to be monitored there. Also want to mention lifestyle interventions a little bit. So alcohol intake can be problematic for raising triglycerides, increasing the risk for pancreatitis. So reducing that can definitely be an important thing. Managing diabetes, dietary changes, those can be important things as well when it comes to triglyceride management. So important things to pay attention to there. And then, again, that key clinical pearl is remembering that fibrates are best used to prevent pancreatitis versus, lowering LDL and cardiovascular risk, which is generally not in its role as compared to statins. All right, I want to thank you for listening to the podcast today. Do me a huge favor, leave a rating, review on iTunes or wherever you're listening. I greatly appreciate that. Comments, questions, concerns, reach out to me, mededucation101@gmail.com. You can also connect with me on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. Do me a huge favor, support the sponsor, meded101.com/store. Your purchases there go directly to help fund this podcast, so I greatly appreciate that. With that said, thank you so much for listening. Take care. I hope you have a great rest of your day.